Things.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الذي خلقني فهو يهدين والذي هو يطعمني ويسقين وإذا مرضت فهو يشفين والذي يميتني ثم يحيين والذي أطمع أن يغفر لي خطيئتي يوم الدين رب هب لي حكما وألحقني الصالحين صدق الله العظीम। मैं अल्लाह की पनाह मांगता हूँ शैतान मरदूत से। शुरू अल्लाह के नाम से जो सब पर मेहरबान है, बहुत मेहरबान है। जिसने मुझे पैदा किया है फिर वही मेरी रहनुमाई फरमाता है, और जो मुझे खिलाता पिलाता है और जब मैं बीमार होता हूँ तो मुझे शिफा देता है, और जो मुझे मौत देगा फिर ज़िंदा करेगा, और जिससे मैं ये उम्मीद लगाए हुए हूँ कि वो हिसाब व किताब के दिन मेरी ख़ता बख्श देगा। ए मेरे परवरदिगार, मुझे हिकमत अता फरमा और मुझे नेक लोगों में शामिल फरमा। I seek refuge with Allah against Satan the accursed. With the name of Allah, the All-Merciful, the Very Merciful, who created me and who guides me and who feeds me and gives me drink, and when I become sick, He heals me, and who will make me die, then will give me life, and who I hope will forgive my fault on the day of retribution. O my Lord, give me wisdom and make me join the righteous. Al-Hadith. عن أبي الزبير عن جابر رضي الله تعالى عنهما عن رسول الله صلى الله عليه وسلم أنه قال: لكل داء دواء، فإذا أصيب دواء الداء برأ بإذن الله عز وجل. रवाहु सहीह मुस्लिम। हज़रत जाबिर रज़ी अल्लाह ताला अन्हु से रिवायत है, वो फरमाते हैं कि जनाब रसूलुल्लाह सल्लल्लाहु अलैहि वसल्लम ने फरमाया कि हर मर्ज़ की दवा मौजूद है, जब मर्ज़ के मुताबिक दवा दी जाती है तो अल्लाह तबारक व तआला के हुक्म से मरीज़ तंदुरुस्त हो जाता है। हज़रत जाबिर narrated, Prophet Hazrat Muhammad Mustafa sallallahu alaihi wasallam said, for every disease there is a medicine. When medicine coincides with the disease, patient heals with the order of Allah subhanahu wa ta'ala. Sadaqallahu al-azim wa sadaqa rasuluhu an-nabiyul kareem.
Jazakallah. Can I now request the esteemed speaker and the chair to please come on stage and take their places. On behalf of the Indus Hospital and the organizing committee, I welcome you to ICON 2018 Day 2. Redefining healthcare has been the driving force of mission of Indus, for free of cost healthcare to paperless environment to the concept of a hospital without a cash counter. So there was no better theme to our conference than redefining healthcare. The ongoing mission also serves and focuses on enhancing quality and safety in healthcare, for which we are all striving. Today's plenary session focuses on this very aspect of quality safety. I would now thank Mr. Dr. Tariq, Rafi, Professor, Vice-Chancellor, Jinnah Sindh Medical University to be the chair of this session. I would like to invite Dr. Adil Haider, Kessler Director, Center for Surgery and Public Health, an active trauma and critical surgeon, a prolific researcher. He is regarded as one of the foremost experts on healthcare inequalities in the United States. His other area of interest is the long-term outcomes of patients in trauma and critical care, and his today's talk is aptly titled Discharged but Not Forgotten. Dr. Adil, please.
Assalamu alaikum and good morning. How's everybody doing? It's early in the morning, right? But you're here, so thank you very much. So I'm excited to talk about, in the context of ICON's theme of redefining healthcare, to talk about how we can potentially redefine the outcome we look at after people get injured. Currently, we all think about when people get injured, how many people are able to live after this. What I'm going to talk about today and propose is that we should change that metric, that we should not change it just how many people's lives we saved, but actually how many people we were able to return to their lives, return to their zindagi, what they used to do before, returning back to work, returning back to school, returning to who they usually are. And that's what I'm hoping to talk about today, and I'm really excited to bring that here for the theme Redefining Healthcare. Thank you. But before I begin, I just want to tell you how inspired I am here after spending a few days with all of you here at Indus Hospital. When you put this up here, Indus equals to quality of care that is free, I truly believe that it's true. And I don't say this as an external observer. Many of you know my family has been involved in a partnership with Pehla Kadam. And as family members, they always look at the children treated from the Pehla Kadam program and say that their quality of care is even better than the care my niece, who has clubfoot, received in California. And so when we say quality of care, sir, we truly, truly believe it. And I must say, Dr. Bari, you're sitting right here. When we met maybe 12 years ago in Baltimore, I was skeptical of how are you going to build a hospital will never have a cash counter, right? I asked you that. And going through the talks yesterday and hearing about all that you do, and especially your talk, Dr. Zafar Zaidi, I was like, what is the thing that keeps Indus afloat? Like, what's that secret special sauce? And it was on your fourth slide, and it was the bottom, which said, we want to do good quality of care, we want to be innovative, we want research, but we also want to please Allah subhanahu wa ta'ala. And I think, if anything, that is the X factor that makes Indus do what it's able to do. So I want to just have a round of applause for not just the leaders like Dr. Bari and Dr. Zaidi, but all of you who shared that vision, who had better vision than me, and came about supporting Indus, like Dr. Lubna Samad, Dr. Amir Khan, Dr. Mansoor, Dr. Chinoy. You guys had much better vision than I could ever see that you supported all these folks. Congratulations. How do these slides move forward? All right. So I just wanted to give these basic statistics because many people have seen that trauma is a giant killer, especially in the United States as well. But the number of people who die after traumatic injury is actually just the tip of the iceberg, right? There are many more people who suffer significant injury after trauma and then have long-term deficits in their outcome. And how I got involved with thinking about long-term outcomes was from a patient. You always learn the best from your patients, and this was a young man who was 19 years old. He got shot multiple times in the abdomen. He was hypotensive, took him to the OR, had major vascular injuries. I took out the right kidney, but his pressure was still sagging. We were giving him a lot of blood. We couldn't bring him back out of the ICU just yet. So I started exploring the other side, and I found that there was a hole through the bottom pole of his kidney as well, on the left side as well. So I've already taken out the right kidney, and now we have an injury on the left kidney. And he's 19 years old, and I'm like, if I take out this left kidney as well, then he's going to become anuric, and he's going to become hemodialysis dependent, which will be a huge problem for him. So even though it's not a good idea, I won't recommend this, but we did a partial nephrectomy on this guy, and we, as a professor of mine said, got away with it, that we were able to still manage his bleeding, and we were still able to get him off the table, and he actually survived. Now, about 2 weeks later, after he got discharged, he ended up having a DVT. And after he got the DVT, he got presented at our M&M conference. And at the M&M conference, it's actually a nice injury to have at the M&M conference, right? Because you're showing this person who would have died, you've fixed him, and now he's at M&M, and I'm kind of thinking, oh, this is a pretty good save. But my chairperson asked one of the transplant surgeons and said, this person, you've saved half of their kidney. What do you think the chances are that this is not going to work and eventually the person's going to need a transplant? And the transplant surgeon, well, let me just put the context. This is Baltimore, United States. The transplant surgeon is white, the patient is black, and the transplant surgeon says, oh, this person's never going to need a transplant. He's just going to get shot and killed by somebody else because there's so much violence in Baltimore that it won't even make a difference. Basically saying that you wasted your time saving this person. Nobody deserves that. And so, of course, I was angry. And in response, instead of getting upset and screaming at the person at M&M, my division director said to me, don't get mad at him, just get even, right? And so we started looking at long-term outcomes of everybody who got injured at Johns Hopkins. We went back 8 years, and we tracked down every patient. And we found that it didn't make a difference if you were injured through penetrating injury, violence, or through blunt trauma. Your long-term outcome, survival, is the same. But when you really talk to the patients, you realize that although they were alive, their quality of life and what was actually happening to them was very, very different. And so since then, we've been trying, and this is just a slide from one of our whiteboard meetings at our research lab, we've been trying to figure out a better outcome that's better than just looking at mortality after traumatic injury. Now, to really understand this, I want to just talk about just a few minutes of why we think about mortality only, even though we all know that there's much more to just life and death. And that's because of mortality being an easy thing to track, right? It's easy to tell if somebody's alive or dead. This is a paper describing the first ever trauma registry. It's from 1973, and that again talked about how many people died and what their time was in the emergency department and all sorts of other things. It was all about preventable death. It was all about survival. Then came the time when people began to figure out how to better risk adjust for mortality, like using the injury severity score and so on. And so there became a lot of work there to help risk adjust and understand who's going to survive and who won't survive. This led to what was called the major trauma outcome studies in the 1980s, and this had several different trauma centers, and they all began to compare their survival rates. How many people survived at one trauma center versus the other trauma center. And in 1989 in the United States, the survival was about 9%. So if you came to the hospital with severe injury, you had a mortality rate of about 9%. Fast forward 10 years, that mortality rate dropped to about 7%. So a pretty significant drop over a 10-year period from 9% to then 7%. And then after that started the National Trauma Data Bank. So now we start to really collect good mortality data from trauma centers around the United States. And many people have worked towards developing the best possible methodology to risk adjust. This is one model that our team from Baltimore created, and we actually looked at every single potential variable in a trauma registry to figure out how best to predict mortality after injury, and we came up with this model. And so now with this model, we're able to predict mortality at about a 97% accuracy. Other colleagues, and I wanted to show this paper, it's from a student from Aga Khan, and he did this while he was a research fellow with us, and he figured out even better ways to risk adjust. And now what we can do is we can plot every trauma center in the United States on a graph like this and determine which trauma center has a high mortality or is a bad trauma center survival-wise, and which trauma center has a low mortality and is a better trauma center survival-wise. And now what we found that from the early MTOS, when you had 9% survival, after using these kind of trauma registries and tracking people and putting out graphs like that and telling people about survival, we're able to decrease mortality to around 4% in 2017. So if you come to a trauma center in the United States, your survival is around 96%. We've also done this for international trauma care, and this is some work that again was done with colleagues from Aga Khan. And what they showed here is that if you plot similarly all those trauma centers in the United States, and then we also plotted a trauma center from France, that was kind of right there in the middle, but we also had this trauma center, and this was Aga Khan actually, its outcomes were over here, a little bit higher than the average, but still better than some US trauma centers. And I first saw this and I wasn't sure that Hasnan is going to like this, but Hasnan was thrilled. Hasnan Zafar, who was the chief of trauma at Aga Khan, he was like, this is great, at least we're on the map. So we can tell how we're doing as far as mortality goes. This is now being used by the Global Alliance for the care of the injured patient, and they're coming up with a minimal data set for mortality for trauma centers. But again, that's just mortality, and the question I propose, can we do something for the other 98% or so who actually survive, right? And this is something that is very important. This, just before coming here, I was coming to Pakistan, so I thought I should get a good haircut. And this is the woman who cut my hair. And I was just talking to her about, I'm going to Pakistan, I'm going to give this talk about trauma care and so on. And then she told me about her story, that when 20 years ago, she actually had a very lucrative job. She was an accountant at a bank, and then she got into a car crash, and then she just had PTSD after it. Several months, and she just could never go back to her usual work. And then years later, she now is a hairdresser, because that's all she could figure out how to do. Nothing against being a hairdresser, it's just a little bit low stress than the high stress environment she used to work in as an accountant in a global firm, right? Because she just couldn't take because of her PTSD. She just never got treatment. And so the only place that I was able to find where people are routinely collecting long-term outcomes was from a group in Australia, in Monash University, and they started collecting, making phone calls to people 6 months after they got injured. And they found some very, very interesting results that are shown up there. Based on this, the recent report from the National Academy of Sciences of the United States said that now we should include trauma registries, or all trauma registries should include long-term outcomes that focus on more than just mortality data at 1 year. So now this has become like the standard in the United States. At least the national academies have recommended that. Based on that, our group in Boston has started what we call the Forte study. And through this study, 3 different trauma centers are now phoning patients up 6 months later and a year later to see how these patients are doing. And here are the aims of what we're trying to do. We're trying to inform the stakeholders of the broader long-term patient-centered outcomes, like what actually happens to people a year or 6 months later. And we want to do this so that individual patients can then make decisions about their surgical care in the context of these long-term outcomes. And then most importantly, since we're talking about quality and outcomes here today, we want to be able to create outcome measures that are based on long-term outcomes. Here's a methodology. We have our trauma registry. We take out all the patients in the trauma registry who have an injury severity score of 9 and above. We phone them at 9 or 12 months. We then collect that data, including patient-reported outcomes, and then attach that data to the trauma registry data, and that's how we end up with this Forte study trauma registry. Several publications have come out of this. The first was a publication on the feasibility, and we found that we're able to get data on about 60% of patients. Here's another tweet of the team that's been doing this kind of work, and we found that by doing this, we've been able to identify and uncover some very, very important things, such as the trauma quality of life study that we're able to do on people. So if you look at that, turns out that after 6 months of following on nearly 1,000 patients, 60% report a current physical limitation. And just look at their issues. A quarter of them take pain medications daily. Half of them said that dealing with their injuries was tough emotionally. So look at the toll of these patients. You know, after getting injured, they all are still suffering 6 months to a year later. Look at this slide. This is very, very significant. 6 months later, a quarter of them screened positive for PTSD. And about 40% of them stopped working because of their injury. Can you imagine that? Like, we saved these people, but then half of them can't go back to what they started out with. Now, we've also done some other work. This is our research fellow, Juan Escobar from Colombia. He's actually the fellow running this program, and he looked at pain outcomes 6 to 12 months after injury and found that there are significant things that predict pain after injury. So, as I mentioned, you know, a quarter of those patients had pain after injury. You'll see that the things that predict pain include PTSD. So if you have PTSD, your odds of pain are much more increased. If you have limitations, or if you haven't been able to return to work, there's an association with pain. So pain is a significant problem for these patients. We also wanted to look at the risk factors for development of PTSD, and what we found was, and I'm just putting up these numbers here, that if you look at it, all of these things here, like injury severity score or any of these things, none of these things actually predict associations with PTSD. So what this is trying to say is that development of PTSD is not related to how severely you're injured. All you needed to have was some sort of significant injury that was life-threatening, an ISS of 9 or above. That would be something like a very bad, fracture to the leg or something like that. As long as you had that significant injury, you were at risk for PTSD. And then finally, I just want to show results of this paper. This compared 3 different trauma centers in the 3 centers that we collect data from, and we looked at their outcomes, long-term outcomes. So instead of just looking at mortality like I was showing before on those butterfly charts, but looking at this one, you'll see that compared to Trauma Center 1, compared to Trauma Center 2, Trauma Center 3, you'll notice that Trauma Center 3 has worse outcomes, increased PTSD, increased 1 physical limitation, increased patients saying that my physical healing is not as good, right? And so we're finding that even within 3 trauma centers, if you just looked at mortality, they all did the same on mortality. But if you look at their long-term outcomes, one of the trauma centers is not doing as well as the other. Point being that I think we can actually look at quality of care, not just looking at mortality, but looking at how patients do 6 months to a year later. So now we've recently submitted this R01 grant where we're hoping to do that at multiple trauma centers, and hopefully that it gets funded. It's quite a large grant. Hopefully it's in study section next month, so we'll see how it does. And then this is my totally biased Twitter poll. I just put it on Twitter before we submitted that grant, just to see what trauma surgeons thought about. And of course, the overwhelming number of trauma surgeons thinks that trauma registries should collect long-term patient-reported outcomes. Of course, this is kind of a biased poll, but we did that just to kind of inform the grant. So with that, the question is, can this be done in Pakistan? After seeing what Indus has done in that 10-year span, the 10x increase from 150 hospitals to 1679, I think Indus is the perfect place. If there was any place in Pakistan that could develop a trauma registry, so when you all start really getting into the trauma business, I think that with your trauma registry, you would be the best place in the country, if not the world, to actually implement long-term outcomes work. And so with that, I just want to leave you with some quotes from patients of how they felt 6 months after injury.
Thank you, Dr. Adil. It is certainly a new way to look at our trauma patients. Now I would request Dr. Mirwais Khan, who is a partner with us at Indus from ICRC, to talk about violence in healthcare, which is a major area which affects all of us equally.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Mirwais. I'm the head of the Healthcare Endangered Project at the International Committee of the Red Cross, ICRC. My today's presentation is an overview of the Healthcare Endangered Project, the issue of challenges in addressing the problem of violence against healthcare, and some of the recommendations regarding the ways forward. Violence against healthcare, the Healthcare Endangered Project, it's a global initiative of the International Committee of the Red Cross. It was launched in 2011. It works in 3 distinct but interconnected areas, creating awareness about the magnitude and the significance of the problem, mobilizing a community of concern who can support in the implementation of recommendation and measures for the prevention of violence against healthcare, and devising interventions to address the issue of violence against healthcare. The aim of the project is to prevent violence against healthcare, and that includes all components of healthcare, including patients, healthcare facilities, healthcare workers, and healthcare transport. Since the initiation of the International Committee of the Red Cross had its beginnings in ensuring the provision of healthcare services to those in need of it, therefore this issue lies at the very heart and spirit of the Red Cross and Red Crescent movement. Just to give you an idea of the magnitude of the problem, the ICRC, together with its partners in 11 countries over a period of 3 years, from 2012 till 2014, conducted studies in 11 countries and collected data on the magnitude of violence against healthcare. As many as or over 2,400 incidences of violence against healthcare were recorded during this period. 4,200 people were victims of these incidences of violence. 598 healthcare workers lost their lives or were wounded. Over 700 medical transport vehicles were damaged either directly or indirectly. And 50% of these incidences of violence were either inside the hospitals or around the facility. The types of violence that were recorded during these studies, they ranged all the way from overt attacks against healthcare facilities to the general outcomes of general insecurity. And all the components of healthcare service delivery were affected, be they the healthcare personnel, the healthcare facilities, the wounded and sick, and medical transport vehicles. In situations of conflict and war, healthcare services are particularly vulnerable to violence. During the conflict in Syria, almost 60% healthcare facilities in Aleppo were rendered dysfunctional or were reduced to rubble. This in a time of conflict when there was an increase in the number of wounded and sick as a direct outcome of the war in the country. In Yemen, 45% healthcare facilities were functional during the time of conflict. However, this problem is not just related to areas of conflict. Urbanizing societies with high population densities have this component of violence against healthcare as part of the broader package of urban violence. And Rio de Janeiro is a classic example of that. Violence against healthcare also happens in developed societies. The kind and degree may differ, however, the problem persists. And one study in Queensland, Australia, reported as many as 3,300 incidences of violence against ambulance staff and hospital staff in 1 year. So where does Pakistan stand? Due to the lack of comprehensive data, the ICRC, together with a consortium of partners led by the Apna Institute of Public Health at JSMU and Indus Hospital being an important partner in that collaboration, they conducted a research study in Karachi employing mixed methods to understand the magnitude and pattern of violence. The idea was to have an in-depth understanding of the nuances of the problem so as to help fashion interventions and to guide policymakers in making their decisions, and to create awareness within the community about this issue. It was a comprehensive data collection. Almost 1,000 questionnaires were filled. There were numerous in-depth interviews and focus group discussions, and the study came up with some very interesting findings. For a city like Karachi, counter to the narrative prevailing in the media, rather than the premeditated violence, the kind of violence that makes it to the news, the murders, the ransoms, the killings based on sectarian and political grounds or ethnic grounds, it was reactive violence, the kind of violence that happens within working environs of a healthcare facility that can happen spur of the moment. It was that kind of violence that was responsible for the major burden of the problem. In fact, the premeditated violence accounted for just over 2% of the violent incidents. A staggering 66% of healthcare workers, the respondents of the survey, they reported having experienced or witnessed, or both experienced and witnessed, some kind of event during 1 year preceding the study. 17% of the respondents had experienced violence, almost 33% had witnessed violence, and almost 17% had both experienced and witnessed violence. What happened as a consequence of this violence against healthcare? 2% of the victims died, 21% were injured, 85% required treatment, and 47% had to take time off their work, overburdening an already overburdened system. 73% of the victims became super alert, 50% experienced hopelessness, and there are reasons why this hopelessness were experienced. 50% avoided to talk about the incident. Over half the respondents, those who had experienced or witnessed violence against themselves, they had disturbing memories of the incident. And 2/3 of the participants thought that the event could have been prevented. Who were the major perpetrators? Again, it was not the kind of actors that we would associate with premeditated violence. It was the patient attendants and general public accounting for more than, who were involved in more than 80% of the incidences of violence against healthcare. So it was basically the service user who was targeting the service provider. And what were the predominant factors that played a role in the development of these incidences? Unreasonable expectations on the part of the patients or their attendants led to developing of these incidences of violence. Communication failure on both sides, but one of the recurring themes during this study was lack of communication skills on the part of the healthcare workers and lack of knowledge about ethical codes that kept repeating in the study, followed by human error and unexpected outcome. That again comes down when the patient or attendant is not prepared or has not been informed about prognosis. So it again is somehow related to the component of the communication skills. And financial pressure and management failure, they come way down the line. They're still pretty significant, but it's some of the reasons that can be avoided and can be tackled by enhancing certain capacities. A disturbing finding of the study was that there was a threshold of acceptance of violence within healthcare workers. It was as if they had been trained or it had been ingrained in them to accept it as a part of their job. The acceptance for violence was there for verbal abuse, for physical violence, and amongst the doctors there was this acceptance for paying extortions. So there was this kind of normalization of this process of violence against healthcare workers by healthcare workers, and narratives like, even if they speak to us harshly, then we've been trained to tolerate it. People are in distress when their loved ones are sick or injured. It is their right to express their emotions. What happened, what was the response of the victims to this incident? The majority of the victims did not take any action, and this again is related to that hopelessness and helplessness. One, it comes out from the frequency and the magnitude of the problem, and second, there is lack of knowledge of institutional policies, or even if institutional policies are there, they are not being implemented. So the victims thought it of no use to report this incident. Again, the reasons for not reporting violence, 46% thought it was not important. It again comes down to that normalization of the issue, and where the healthcare workers have this threshold of acceptance for violence against themselves. 30% thought it useless to report this incidents, and almost 14% were afraid of negative consequences. The qualitative component of the study gave an in-depth insight into the causes of the problem, and the causes can be categorized into three main categories: behavioral, institutional, and socio-political. The behavioral causes can then again be classified into client-related and provider-related, or the healthcare worker-related. Reaction to adverse outcomes and impatience and lack of respect for healthcare were main reasons identified during the qualitative component of the study. On the part of the healthcare workers or the healthcare providers, apathic attitude and lack of communication skills were identified as the major reasons for violence against healthcare. Amongst institutional causes, capacity-related causes, where the healthcare providers did not have the kind of skills required to provide high-quality healthcare services, and mishandling of cases were reported as leading causes. Resources constraint, lack of medicine and equipment, they were an important cause of the violence. And institutional mechanisms such as lack of policies, lack of reporting mechanisms, they were also important causes for violence. Amongst the socio-political, it comes down to the law and order situation, lack of education, and the general civic lack of awareness within the general population. Those were the important causes of violence that came out from the qualitative arm of the study. What can the government do, or government associated bodies can do? They can reinforce national legislative frameworks. We have conducted legal reviews in Sindh and KP, and we have found that there are gaps in the comprehensive coverage, legal coverage for healthcare workers. So that is an area that needs to be addressed through legal interventions. Ensuring respect for ethical principles of healthcare and protection of healthcare personnel adhering to these principles. Establishing mechanisms for data collection, analysis, and reporting. There are bodies within the government setup who can take this task. The healthcare commissions in KP and Sindh are classic examples, who can establish their, in fact, it is a kind of a part of their mandate to collect this data. So there is this high need. Until and unless there is this in-depth understanding of the problem, fashioning interventions to counter this issue, they would not be as effective. And promoting regular cooperation and exchange of information, reinforce domestic accountability mechanisms and regulatory frameworks. The healthcare community, being a part of the community of concern, has an important role to play. As was mentioned, there are certain skills that can be imparted and which can help in reducing the incidences of violence against healthcare, and the onus is on the healthcare community to train healthcare personnel, promoting knowledge and respect of ethical principles of healthcare, improving preparedness, safety, and security of healthcare personnel, promoting the integration of relevant rules of law and the protection of healthcare and the rights and responsibilities of healthcare personnel in the curricula, promoting research activities and public debate. This is one issue which again is missing from the social discourse. One of the findings of the study was that one of the ways in which the disrespect for health manifested itself was the obstruction of ambulances by general motorists. However, amongst all the issues being discussed in the media, that is one issue which we rarely come across. Initiating or participating in efforts to persuade the government. The healthcare community has to play the lead role in advocacy with the government. Similarly, the academia and civil society can provide trainings on rights and responsibilities and the respect of healthcare workers in schools to students and in that phase of the lives of our citizens when they are forming their behaviors. Integrate the problem of violence against healthcare in curricula, conduct research, and join the public discussion and look for possibilities for cooperation with the government, medical associations, and other stakeholders. And they have to be the advocate for the respect of healthcare personnel and patients. So this was a brief oversight of what the local context is. When the project was launched in 2014 with a consortium of partners including Indus Hospital and the Apna Institution of Public Health. Based on this evidence-based, some interventions were developed to enable the healthcare workers to help in reducing the incidences of violence against themselves. One of that was the development of a training module, a training course for the healthcare providers. It provides an understanding of the issue of violence to healthcare workers, enables them to acquire de-escalation techniques, which are verbal and non-verbal techniques, to identify early signs of emerging violent situations and to manage them, to improve their communication skills, especially context-specific breaking bad news. And it enabled the healthcare workers to have psychosocial self-care. The trainings have been piloted in various hospitals in Karachi and in Peshawar, in Lead Reading Hospital. All the emergency staff of the hospital, they've been trained on this module. Lead Reading Hospital is now integrating it into their training regime for their healthcare workers. An impact assessment of these trainings has been, or effectiveness of these trainings has been assessed by a mixed methods study. Although there was not a significant reduction in the number of violent incidents, however, based on the confidence to cope with patient aggression instrument, the healthcare providers who had been trained, they had greater belief in their abilities to manage situations of violence and scored better on every indicator in that instrument than the control group. Similarly, the project has developed curricula for medical, dental and nursing colleges. It again is similar to the components of the trainings, but the idea is to integrate into the curricula for the undergrad students, so that the next crop of our healthcare workers or healthcare providers, they have the necessary skills, communication skills, ethical skills, so that they can control the factors which are within their control for reducing violence against them. Similarly, a tool has been developed which enables policymakers, hospital administrators to assess the safety and security or their preparedness for ensuring that the continuity of their activities happens in case of a violent incident inside a hospital. Our colleagues in our project partners in JSMU, they've been able to contextualize the tool and pilot it in 3 hospitals, including Indus, and the results have been shared with the administration confidentially. This tool enables healthcare administrators to prioritize the areas of interventions to ensure better protection for healthcare workers. One of the logical next steps would be to integrate it into the working mechanisms of a body like Healthcare Commission, so that at the time of licensing and registration of healthcare facilities, steps are taken that ensure the prevention of any kind of violence against healthcare workers. And now this is a very messy slide, but I'll just give you the spirit of it, and it is that based on the hospital assessments, the team at JSMU has been able to develop a framework identifying 4 main areas which the administrators they can or hospital managers, they can prioritize for their decision making, and there are further steps, detailed steps, which can be broadly classified into low cost and easily implementable steps which can have significant impact on the reduction of violence against healthcare. And then there are long-term steps which are more resource intensive. Legal interventions have been carried out, and as after the legal reviews of KP and Sindh, we've been able to sit with the relevant government authorities, and the issue of obstruction of ambulances, we are at that stage where we have come up with proposed amendments to the existing legislation. In KP, we are in negotiations with the government to take the outcomes of the legal review to their logical conclusion, which would be the comprehensive legal coverage to healthcare workers against violence. As I said earlier, one of the issues that was mentioned repeatedly during the study was the way in which the general disregard for health care manifested itself. It was the obstruction of ambulances by the general motorists. To address this issue, the ICRC, together with its partners, it came up with an awareness campaign in 2016, with the lead role being played by the Indus Hospital and Apna Institute of Public Health. This awareness campaign was carried out in Karachi. A proper impact assessment, a scientific impact assessment of this intervention was carried out, and it was found that even with a 1 month multidisciplinary awareness campaign, an improvement of 16.2% was achieved in general motorists in the short term. Building on the confidence that was generated by that campaign, this time the campaign has been conducted nationwide, and we are again thankful to Indus for being so active in that campaign and helping us spread the message. The campaign, it employed various media, including print, electronic, and social media. We are going to conduct an impact assessment of that as well. The future for the project is to keep advocating with the relevant bodies for the necessary legal and policy changes, to integrate the curricula and trainings that have been developed into the working mechanisms of healthcare facilities and healthcare educational bodies, keep developing interventions that are effective in reducing violence against healthcare, and to keep expanding the evidence base. Following the Karachi model, we have conducted a research study in Peshawar. We are done with the data collection phase, and we'd be soon publishing the report of that. The idea this year is to go nationwide and have a comprehensive picture of the issue in the country. Before leaving, I would like to show you the videos that had been prepared for the campaign. If I may have your help, please.
सुबह के 7:45 बज रहे थे और ट्रैफिक बहुत था। फिर मुझे सायरन सुनाई दी एम्बुलेंस दिखने से पहले। अगर मैं रास्ते से हट गया तो मेरी जगह चली जाती। मेरी बीवी मुझे फ़ोन करी थी, लेकिन मैंने नहीं उठाया। अभी बहुत अहम मीटिंग थी, जो कि काफ़ी अच्छी हुई। तब मैंने अपनी बीवी को फ़ोन किया, उसे खुशखबरी सुनाने के लिए, जो कि उसने पहले ही घंटे पे उठा दिया।
थैंक यू।
वो कह रही थी हमारी बेटी आज सुबह सीढ़ियों से गिर गई, एम्बुलेंस टाइम पे हॉस्पिटल ना पहुँच सकी।
May I now request Professor Tariq Rafi to say the concluding remarks?
Bismillahirrahmanirrahim. Nahamdu wa nusalli ala rasulil kareem. It is very enlightening and to see such a big crowd in the early morning on a Sunday. And the first speaker, Mr. Adil, spoke very well about the trauma. We need to have a trauma registry also in Pakistan. That's the need of the hour. The Karachi is one of the cities which have faced more of the violence than any other city in Pakistan. And we are regularly facing it. The violence is not only which is because of terrorism, the violence is also because of car accidents, other things. And we have got major hospitals in Karachi which deal with those violence. I think Indus Hospital can take the lead, as Adil has suggested, in starting this registry of the trauma, so that we should have our own data, and this should not only cover the trauma that leads to death, also of the patients who survive and what is the long-term survival and the problems that they face later on. The second speaker, ICRC, and we are a partner as a university with ICRC in healthcare in danger, and we are grateful to ICRC for bringing this project to GSMU. This project is of great help to the health workers and also to give us an insight of what violence that we face. People were first scared to come out with the violence that they face because from the attendants or from the others, but now the people has given more insight and more knowledge And we have been training people on how to face and how to overcome this. It's going to be a great success, I'm sure. And at the same time, the campaign that they have started for giving way to the ambulance, as mentioned, in a short time has shown an improvement of around 16%. If this campaign goes on, then we will be a much learned and a much disciplined country to know what the importance of giving way to the ambulance is. I'm thankful to Indus for giving me this opportunity to be here. It's a great pleasure always to be there with Indus Hospital. Thank you very much.
Thank you. Can I now request Dr. Naila Begansari, Co-Chair Scientific Committee, ICON 2018, to present the shields to our esteemed guest. Dr. Tariq Rafi. Can I now request Dr. Adil Haider up here for receiving his trophy? Dr. Mirwais Khan. Thank you, everyone.